Good afternoon and welcome everybody to this final afternoon of the Child Health Priorities Conference. A lot of time when we're talking public health, we focus on the things that could go wrong and all the things that the risks that we're trying to mitigate against. And sometimes we lose the vision of what could go well and what could go right and what we're actually straining towards. We're trying to avoid a catastrophe and we're not looking towards a good outcome. And so for this session, Friday afternoon, we wanted to ask some colleagues to share a vision of the future which is inspiring and to give us hope, a vision for something that could go well, things that could go well. So that's our theme for this afternoon. What does the future of effective pediatric care look like in the next 30 years? And we've got Natasha Rhoda, a neonatologist with a public health interest from Cape Town, Chris Sutton, general pediatrician with all sorts of special interests from Limpopo, and Mark Tomlinson has got a huge investment in early childhood development from Stellenbosch to give us a vision of what the way they see effective pediatric care in the future going ahead. So let me hand over to Natasha if you want to take it from there and share your screen and talk us through your vision of the future. Thanks, Natasha.
Thanks, Dave, and good afternoon to everyone. You can see my screen, I hope.
Yeah, we can see. That's great. Thank you.
Okay, great. So maybe I should start off by saying I wish to thank the organizing committee and Dave in particular for allowing me to dream of neonatal care in 30 years' time. I must add that it's not often that you get the chance to speak your mind freely, especially knowing that it might rescind everything you've done in the last 30 years, having qualified 30 years ago in 1994. But I think this logo, pediatricians are familiar with this logo. It's the Rota Health Card, and it's the children's passport to good health. It's a powerful tool. It promotes children's optimal development. It keeps a record of children's health and medical treatment, and it enhances the continuity of care. But what if that child is the most vulnerable and voiceless person in our society? Well, the Rota Healthcare booklet actually starts with a live birth. And when we think of neonatal care, this is often the picture that comes to mind of a small and sick baby connected to tubes in desperate need of interventional medical care. And we, the audience, are well equipped and trained to do that. But if you allow, I would like to take you on another journey, a journey of the ABCDs. I'd like to scramble that a bit for you in the next 6 minutes. And so we'll start with environment, or the ecosystem. You are familiar with all of these slogans in parentheses, and they change over time. 30 years ago, when I was qualified as a young doctor, it was all about Gobi FFF. And fortunately now, it has finally included the mother-infant diet with every mother, every newborn, everywhere. But how does one implement a diet care in an environment we currently work in, which is highly medicalized, without mothers, and overcrowded? I do encourage you to read the Brazilian Health Journal in the Lancet series of 2011. There were 6 papers. Brazil is a society not unlike ours, where reform was driven by civil society and not governments, but a bold and purposeful move to be patient-centered, where community participation at all administrative levels is promoted. 3 decades ago, Brazil's under 5 mortality rate was 60, and the neonatal mortality rate was 26. Today, Brazil has 4 times our population, but an under 5 mortality rate half of ours at 14, and a neonatal mortality rate less than 10. So they must be doing something right. Countries around the world have shown us that it does take a village to raise a child. In India, healthcare workers are trained to provide curative care, such as giving antibiotics, the first dose. And in Ethiopia, the health extension workers are empowering families. I've made accessibility, and especially the great divide that exists within our beautiful country. B, I've done as birthplace. And so what matters most for a parent is actually the place and space where babies are born. We are familiar with the first photo with the father and mother in the theatre, and often scornful of anyone giving birth in the comfort of their home, despite the irrefutable facts I've highlighted on the left. Holland has shown now that safe home births are possible, and mothers are choosing that. And recently, in my own family, my cousin had chosen that for her birth. What about D? I put D down as development or follow-up, because tracking growth and morbidity in our population of neonatal babies is extremely important, and this, I think, should happen in communities. Post-discharge is a vital part of neonatal care, especially after spending millions on survival. We need to put thought and funding into ensuring the neonate thrives post-discharge at home. So perhaps we need fewer pediatric clinicians in hospitals and more community pediatricians closer to the babies' homes. And perhaps our OPD departments should move into the townships and provide the supportive care in follow-up that we know works well. The latest evidence, and this is all since 2022, is showing now that the pendulum is swinging, both in high-income and low-income countries, albeit at different economic investment cases. And what we're seeing now is that IKMC, mother-infant dieets, are being practiced in Zimbabwe and Uganda after the IKMC and the Umwama trial. And in the high-income countries such as Finland and Sweden, NICU couple care is now the order of the day and showing great benefits. Spaces for babies in hospitals are also changing, with dedicated dyad space, where red marks the mother's spot in the unit and the green for couples. So what are my take-home messages? In the future, I see 5 Ps, and I'll start off with policy. Perhaps we should be shifting to community pediatrics and hospitals designed to keep the dyad together. Spaces and places are important, both for birth, care, and follow-up. Personnel should be empowered, nursing staff and midwives, and they should all be singing from the same hymn book, education-wise. And then, of course, there are the parents. The parents, such as mothers, should be empowered through education, and I give an example of the BILS training being done at Mowbray and elsewhere, task shifting, and definitely longer maternity leave, and not forgetting the other 2 Fs, the family and the father, and inclusive family care. But there is a 5th one, and that is the PPP, the public-private partnership. Unexplored largely, but game-changing, as shown in Nigeria, where soap was provided to a hospital adjacent to the private hospital, and mortality decreased by 10%. I thank you for your indulgence, and I think I've cut the 6-minute mark. Thanks, David.
Brilliant. Thanks, Natasha. That's very challenging. And as you say, definitely not the traditional paradigm of neonatology. That was really quite an interesting journey. Thank you so much for that.
I think the 20 minutes will counter what you're saying now. It's very much the domain of neonatology.
Not where we've been trained to think about it. That's wonderful. Yeah, that's great. Cool. Thanks, Natasha. I'm going to move across to a slightly different headspace now, to hear from the rural dimension. So, Chris, I'm going to play your video and then hand over to Mark So let me just get this sorted out.
Have I stopped sharing?
Yes, please.
Good afternoon, and thank you to the Child Health Priorities team for the invitation to speak at this event.
Can you see and hear that all right? Is that coming through?
It is.
Okay.
I've chosen to keep most of my 5 minutes shamelessly focused on specialist pediatric services, but I hope that what I describe will encourage a lot of lateral thinking about what is achievable in 10 to 30 years' time. I'd like to start with a little bit of context and ask you each to pause for a moment to reflect on what rural means to you. Here I have depicted two land masses with similar populations, similar numbers of children, and similar population densities. The dark brown areas are zones of high population density, and the yellow areas low density. Most of you will recognize the Western Cape, which is considered to be 10% rural, and I hope many of you will recognize Limpopo, which is about 90% rural. Although there is no single consensus definition, in general, rural defines a population that is quite widely, but by no means evenly dispersed, over a geographical area. We also tend to think of rural as being associated with less wealth and poorer health outcomes, and I have based some ballpark figures from neonatal mortality rate and under 5 mortality rate around the Medical Research Council national estimates. We also think of rural as less well-resourced. It was difficult to get a reliable figure for the number of pediatricians in the Western Cape, but I rough estimated 200 in the public sector, and I'm sorry if I'm horribly wrong on that. Now, as a little exercise, consider what might happen if we took away all the public sector pediatricians from the Western Cape and replaced them with the 30 from Limpopo. How would you restructure the pediatric and child health services? And in 30 years' time, if allowed, would you want to rebuild exactly what had just been taken away? I arrived in Limpopo province in 1998. As far as I'm aware, there was one full-time public sector pediatrician working in Limpopo at that time, and that was the then Dr. Nancy Shipalana, who was working at Letaba Hospital. A small stable core of three pediatricians was established, based around the two central hospitals, Pietersburg and Mankweng Hospital, shown in red crosses on the map. Under the leadership of Professor Shipalana, we set about building a team of specialists and developing a pediatric-led clinical and child health service. I wanted to use this opportunity to pay tribute to the late Professor Shipalana, who was an immensely selfless and courageous leader, as well as a wonderful pediatrician. The pediatric services in Limpopo would be much poorer today without her leadership and determination, and I hope we shall find a way to remember and celebrate her and her work on a regular basis. Fast forward almost 30 years, and the little black dots represent pediatricians. A few handfuls clustered at the central hospitals, and between 2 and 4 at each of the regional hospitals, Chilidzini, Letaba, St. Rita's, and Mokopane. Various subspecialty services have been inaugurated and facilities and equipment improved. It seems unimaginable now that there was no public sector CT scanner 30 years ago, and now there are scanners in both central and regional hospitals. A medical school is opened, and 3 cohorts of about 60 doctors have been graduated, and 24 pediatric registrars are being trained. In the midst of what looks like rural bushveld, but is in fact the edge of Polokwane city, a new central hospital is being built. There has been an active child health program, although the district clinical specialist teams were dissolved in favor of integrating the child health services as a regional hospital responsibility. I focused shamefully on paediatricians because it is an area I know well and it serves as illustrative. Other health worker numbers have also increased substantially throughout the province. I also do not want to suggest that these changes are limited to Limpopo. There have been even more impressive developments in other rural provinces of South Africa, and I think that we should celebrate all that has been achieved in the last 30 years. We have confronted and managed HIV and COVID. Cell phones arrived and smartphones are becoming ubiquitous, together with internet access. So where does the next 30 years lead? Healthcare resources will continue to improve in rural areas, and hopefully there will be greater equity in terms of geographical distribution. Populations may urbanize, but based on previous trends, I think significant urbanization is unlikely. We already know what we are not doing well enough. Will we be able to leverage technology to enhance communication and improve waiting times for preventive care? Can new therapies bring less reliance on clinic and hospital visits, allowing more care to be provided at home? Will drones deliver medicines to remote communities? I know you will have heard about the potential role of artificial intelligence and technology and shared many ideas over the past day and a half. Ultimately, our level of success in helping children to survive and thrive will depend on a cohesive advocacy for the strategies that provide best value for money. We need to set aside personal agendas in favor of collective ones, to synergize instead of competing. As Nelson Mandela wrote nearly 50 years ago, a good head and a good heart are a formidable combination. Even more so, many good heads and good hearts working together. Thank you.
Brilliant. Thanks for recording that for us, Chris. Chris is now live with us, and we'll be we're going to direct questions to you in a minute. Thanks, Mark, for joining us today. It's a great support of the Child Health Priorities Association. Mark, do you want to tell us your vision of the future of early childhood development?
Yeah, thanks, Dave. Can you see my slides and everything?
Yeah, we can see your slides and your camera. Thank you.
Cool. Thanks, and thanks for the invitation. And yeah, lovely to see a lot of people that I know. Being old and graying and everything, I didn't listen to the instructions properly from Dave, and so I'm going to do something slightly different, but hopefully it'll be interesting. I was always also aware that this is a session on a Friday afternoon of a virtual conference, almost at holiday time. So I thought I'd try and mix it up a little. I'm actually not really going to talk about early child development. I'm going to talk about children, and I'm really also going to talk about politics. And I put that little sort of reminder there, remember that hope is a virtue. And it was from a podcast I listened to early in the week, and it was Philip Pullman, for many of you might know from, The Dark Materials, not a trilogy anymore. I think they're now 6 books, but, and that actually we don't have any choice. We don't have a choice regardless of what's happening, but to be hopeful and to hold on to that in what, as we all know, are quite dark times in many respects. So yeah, declaration, no conflicts to declare. This is one of my favorite quotes from Enrique Peñalosa, the former mayor of Bogota, Colombia, who was talking about building a successful city. But I like the first part of that particular, that children are a kind of indicator species, and that when things aren't going well for children, we should take note, because the chances are they're not going well for any of us, and that children are a kind of canary in that proverbial gold mine. I also want to state my kind of like colors up front, that I think child health and child development is always political, and that it's of course about clinical care, but it's about so much more. And I've spent my research life, I'm a clinical psychologist by training, trying to design interventions, trying to design programs, tracking, child progress over time. And I'm increasingly getting to the point where I really believe that we need to do something. We need to do something big. call it a revolution, call it sort of some severe disruption, but that we're not doing what we need to be doing for sort of the environments of the children in our families, in our countries, and in our care. So in terms of early child development, I just put the slide up. These are a few of the packages that I just picked up very quickly from the World Health Organization. This doesn't include UNICEF, UNESCO, any other number of agencies or NGOs or anything, or governments. So this is just some of the work that has been done. So basically, we do know what to do, but something's happening and we're not doing it. And I want to try and speak a little bit about why I think we're not doing it. This might come as a surprise that I'm putting Sam Altman from OpenAI up front, but this is a quote that's been bothering me for about like 3 months now. And it's something he said in I think it was towards the end of last year. And he described, and he said, infants, take years to learn anything interesting. And then he said, if artificial intelligence researchers were developing an algorithm and stumbled across the one for a human baby, they'd get bored watching it, decide it wasn't working, and shut it down. The fact that somebody who is this powerful can say something so gothically ignorant, I think is less important than the fact that this is the kind of person that's making, that is holding the narrative of so much of where the world is going, of where the world right now is. And I think we've failed, people involved in advocating for child health, for child and adolescent mental health, for child and adolescent development, that this is the kind of narrative out there. And basically my vision in terms of 30 years is that actually the people talking about what infants can actually do and what children are doing is said more by us than about people like Sam Altman. I've also recently been doing, and as I said, I'm a clinical psychologist. I'm not a medical doctor, a neonatologist, a pediatrician. But I've increasingly been interested in and reading about the work of Paul Farmer, and particularly the sense of accompaniment. Which and I'm sure many of the people on this call know a lot about what he meant by accompaniment, but it was this idea that it's much more important around in terms of the care of those in our care, in whatever way it is, that we're there lending solidarity, a shoulder, a sounding board, a word of counsel, that we're empowering, not enabling. And I want to add there, very importantly, and when you watch some of the work of Paul Farmer in videos that have been made of him over the years, I mean, he died a number of years ago now, but the seemingly infinite capacity to listen and wait and let people describe their worlds. But he also meant that accompaniment was incredibly difficult, because part of it was to walk with patients as they suffer from structural violence, the violence of poverty, of racism, of illiteracy. And the example I speak a lot about, and it's linked to an example of a case that we had in one of our research studies of an adolescent girl who was pregnant and who went into a health clinic and basically was kicked out by a group of very angry nurses at the fact that she'd been, in their terms, sleeping around. And I often use that as an example to say that when an adolescent pregnant woman goes into a primary health clinic and a nurse is caring and empathic, as many are, and I'm fully aware of the difficulties in many cases of what nurses face, but that when she's met with empathy, with care, that when she's listened to, that when something of this kind of accompaniment happens, that's possibly the most profound intervention that anyone can do for that girl, for the unborn baby, and it's a mental health intervention, it's a child health intervention, it's a maternal health intervention, and that we need to find a way, I think, and that's for me is this idea of a different kind of accompaniment and care, is what I would like to see in 30 years' time. Second last slide is this was a commission that I was part of a number of years ago, and it made a case, and it's something I've been pushing relentlessly since around. I think that children, this is what the commission was about, is that children should be put at the center of all our decision making. And that means all our decision making. So when the Department of Defense is deciding to build another battleship, that child advocates are in the room, the Children's Commission is in that room, that whether unless a case can be made for how that benefits children, the battleship shouldn't be bought. And the children should be at the center. And if we create a world, and as Penelosa said, we create a city for children, then everyone benefits. Grandparents benefit, elderly benefit, everyone benefits. And so that's another thing I would like to see. And then my last slide, and this is the one that usually gets people sort of smiling thing, is if we believe in the notion of child engagement, engaging with children and hearing their voices, we've got to do something very differently, because it can't just be a tick box. And linked to that is, if we do believe in universal suffrage, if we are going to allow people who are 107 to vote, and I'm not for a minute saying that they shouldn't, but if we're going to believe in universal suffrage, then we have to think about why we only allow children from the age of 18, young people from the age of 18 to vote. So my proposition to in a sense, completely disrupt things, and this is a start, is that all children from the age of 12 should be allowed to vote, and that there are very few reasons. In fact, there are almost no reasons that anybody can come up with to argue against that. If you're going to argue competence, well, then we would have to test the competence of 106-year-olds, and we're not going there. So that's not a question. And most arguments for that, for example, children will be told by their parents who to vote. Well, as many of you know, those were the very reasons that people used to stop women voting, because it was their husbands that would get them to vote. So in order to ironically improve early child development in 30 years' time, I think we should allow children from 12 to vote, and that would be a really good start. Thank you.
Brilliant. Thanks, Mark. Thanks for that that vision of the future. For taking us on a view of the way you see things, how they could be. There's some questions in the chat that I just want to bring out. If you've got questions for Mark or Chris or Natasha, please will you pop them in the chat or raise your hand, and I can unmute you that you can ask it out loud. Natasha, there's a question here from Ruth Davidge. What do we need to do to make it a reality? I really believe we need to start setting national targets for implementation and effective coverage, not just mortality.
Yeah, I think a good start, and I think what I wanted to bring to the fore is that, in fact, we have been trying for a very long time as clinicians, as doctors, to be the voice of the children, when in fact they've got a perfectly good, abled voice, and those are the mothers. We're just not listening. So part of the change that happened in Brazil, for example, was 40 years of actually teaching people their rights, their health rights, what's due to them, what they should be expecting. And once we get to that, I don't know if it's a cliff, but we need to get there. At the moment, we've been crunching numbers, putting out numbers, talking about survival. We haven't gone that extra mile to actually go to communities to see what they're thinking of. Qualitative research is very new. If you start asking people exactly what they want, you'll be surprised. It's not anything that we're actually giving them. And so one of the ways of implementation is to start listening to the best advocate for that baby is the mother. And this whole idea of medicalization of care, I'm not saying there isn't a place for it. Of course there's a place for it, but it's all been built around a sick baby. Hospitals and incubators are around sick babies, not about well babies, which is why I put the ILCOR 1% of the 100 require incubation, the others don't. Equipment graveyards, all those things, they're all there because we put them there, not necessarily because they need to be there. And there are different ways of doing it. And if we are so good at following examples, then perhaps we should follow the examples of what's happening in Scandinavia. It's a paradigm shift, but it's not new. It's been going for more than 10, 15 years already. And they've shown the data. Bogota, Colombia, the South American countries, they seem to be getting it right. I think what worries me is there's a wave coming into Africa and our voices aren't strong enough maternal voices in Africa are not strong enough. And that does worry me, because we might just repeat all the mistakes of the past. That's a big worry.
I wanted to push back a bit on your home birth proposal.
Please, yes.
We see terrible outcomes of outborn babies who are unbooked, didn't access antenatal care.
That's not a home birth. That's an accident.
BBA.
So there's a difference.
Yeah.
So what I'm talking about are not the mistakes, not the things that happen because someone didn't book, etc. I'm talking about a supported home birth, a supported, safe home birth. And this notion of traditional birth attendants, which only belongs in LMICs, is nonsense. Any skilled birth attendant, we are skilled birth attendants in hospital. It's the place and the space we need to start thinking about. And I give you another example if we wish to follow. The Dutch have got this really right. There's a choice to the mother. What would she like if the screening is normal? She can choose to have the child at home. If she so chooses, there's a supportive network around her. Again, 1% needs intubation. So it's just how you look at the information that's important. But it's not, I'm not talking about the unbooks. You know, you don't book, you deliver the baby at 2 in the morning in the cold. I mean, nobody wants that. That's not what we're talking about. We're talking about a safe, attended space, a home birth. And I've told you now, a very close cousin of mine chose that for her low-risk child. It was beautiful. And it happened 2 weeks ago. It just makes you think. There are the norms that we become accustomed to and we don't question. And if you're looking at the pendulum, because in neonatology, pendulums swing all the way. At the moment, we in gentilation, we try not to intubate. It's the same with mother-infant dyads. It's taken the WHO maybe 100 years to put Iweni together finally, or to resurrect it. They spoke about it in 2016. It just never came to fruition. And part of the problem is, as Tomlinson will tell you, there are too many things going on that are all doing the same and not pulling in the same direction, even at WHO level, UNICEF level. There's not a united voice. And in many instances, there's no voice for the mother. And that's the problem. But safe, supported home birth, David, please.
Promoting access to antenatal care, because unbooked is a thorny problem.
But home births are not unbooked, David. Home books are booked that are delivered at home.
But promoting the context where people choose to access antenatal care because it's considered valuable and it's
absolutely. Absolutely.
So a question from Haroon. Can I open this for Chris? What has been the single greatest achievement in your field in the past 30 years that gives you hope for the next 30 years? So I think, Chris, you mentioned quite powerfully the staffing that you've seen changing in your career in Limpopo in the last since you've been there, and the way that will affect the future. What are some of the other things that you feel have been particularly important for rural pediatric care?
Yeah, thanks very much. That's maybe surprise everybody, and that's, I'm going to say, I think that prevention of mother-to-child transmission is probably the single that it took a new disease to require a new solution for something so big to happen. But, you know, and when I reflect on that, what I'm thinking about going into the future is, how do we harness all these new wonderful opportunities that are coming to us from technology? And I'm thinking just about cell phones. So alongside that, I would say the emergence of the cell phone and the smartphone and the internet is perhaps another huge thing that has happened, because 30 years ago, to contact somebody, to communicate to them a result or call them for a treatment or something, you would have to phone a police station or a clinic by two-way radio maybe, and get them to drive to a house with a fairly non-specific address, call somebody, give them a second-hand message and hope it would come through. Now, I can WhatsApp my patients on a cell phone, a smartphone. it's just a world of difference. The power of that, the power to get the care and the tools we have to everybody is there. And the saddest thing is that, you know, if I look in Limpopo, we still have children who slip through the PMTCT net, and children who slip through the follow-up net after birth. And those are the things we just need to get completely right. It's the human passion that needs to be strengthened and encouraged. Thanks.
Baljet comments here about telemedicine will change the future of pediatric and child health services, rural but also urban. And you mentioned the possibility of drone deliveries. Do you see any other impact of telemedicine for rural child health care?
So telemedicine hasn't initially started. We actually had it installed. And what we found was we were so busy doing other things that it wasn't that cost effective to go and sit in the telemedicine unit and try and get through all the logistical barriers of making it work effectively. So telemedicine, where there's a camera in a room where somebody has to be with a doctor, in that sense, I'm not impressed with it. But the fact that we now have communication opportunities like WhatsApp. So we obviously WhatsApp a lot of information between ourselves and district hospitals, and I hope the same goes on between district hospitals and the clinics they serve. And I think there's a huge opportunity there, and I think we do take advantage of it.
Yeah. WhatsApp is amazing, and a lot of the technology and apps that was presented this morning also changing the way we share information and connect with each other, but also with patients and families. It really is powerful. Mark, is it the question for you? How do clinicians walk with their patients in the current widespread poverty and violence in communities?
Thanks, Dave. I tried an answer there in my reply there. I think Paul Farmer and his notion on accompaniment, I mean, most of his work was in Haiti and Rwanda. So, you know, it was in context of poverty and violence and post-genocide. And so I think it is, and I think it also speaks a little to what Mary was saying. How is it how do we make it political? I think it's about listening in a slightly different way. People often, when you talk to them, have very, very deep understandings of where symptoms come from, and that often will relate it to violence, to poverty, and simply bearing witness is part of that accompaniment, and not simply kind of just listening to the symptom, which is obviously essential. And I'm not a medical professional, but I do think that bearing witness to people's lives in a slightly different way is accompaniment. And I think it can be profound, and I think it can be political. It can be political in how there are many people on this call who I know who are seniors, and how one teaches your interns, how one communicates where these things come from, and that it's not a natural state and order of things that people who are poor were more likely to die in COVID. And what does that mean? What does that tell us about lifetimes of poor food, poor nutrition, smoke inhalation, and all the things that lead to that? It's not simply a biological mechanism. It's profoundly clinical. So it's also in how we teach. Thanks, Dave.
And what do you think is the biggest breakthrough development achievement in child development in the course of your career?
Yeah, in the last 30 years, I think it has been what a lot of the brain science, when that started happening, and we all knew that long before that, but I think that brain science allowed a different kind of advocacy to take place with finance ministers, with a whole lot of people and government ministers that then started listening, and then that created, I think, the fertile ground for the notion of the first 1,000 days for early intervention, and I think that for me it's been massive, I think very, and again, people on this call all knew, 50 years ago, whatever, that early intervention was important. But I think that shift allowed us to get into places and into rooms that we weren't able to get into previously. That's what I would suggest. Yeah.
Yeah, and I think just moving away from the very narrow focus on child survival and infant mortality, to recognizing the bigger dimensions and thriving and development. That's certainly been a great development. Yeah.
Yeah.
Yeah. And that idea of a child being an indicator species is also quite powerful. If you think about our health systems and our government spending, to what extent that we are looking at the health of children as an absolute indicator of the health of our society.
Totally. I mean, I think the figure I always is that rich countries between March 2020 and November 2020 managed to find $14 trillion. When people say to me the money's not there, that's rubbish. The money's there. It's just that we don't put it in the right places. And because children, I think increasingly are finding ways, and we're finding ways to properly listen to children. But because they haven't, and obviously a 1-year-old and a 6-month-old cannot advocate for themselves. And I think so what Natasha was saying is we need to find ways to make sure that parents become effective advocates, that they're aware of their rights, but also that and everyone, all of you again on this call know that in South Africa and much of Africa, a lot of caring is taking place by older siblings who are able to advocate. And so let's get those adolescents and those young adolescents and the siblings into the places where they can start advocating as well. And so it's not just this, well, at some point they'll become conscious, they're not like Sam Altman, infants are not doing anything interesting. So at some point they become interesting. At some point they know they're there right from the start, and we need to find ways to make sure that happens. Yeah.
And lowering the voting age might be quite powerful to nudge that process along.
If nothing else, to get politicians to actually find a way to talk to children, because they don't, and so yeah.
Yeah. So question from Deirdre. We need to find a way to share these excellent advocacy messages with other key role players in health. Many of them, like quality teams, district extra and DHMT members, share the same concerns but can't dedicate 2 full days to pediatrics. Could we consider sharing the presentations in small manageable bites, perhaps 1 per week via WhatsApp groups for district directors and other provincial district managers? This could help spread the message effectively. Yeah, I think that could work. I think there's great suggestions and ideas that have been presented here, which would really be well received if carefully presented at the right time and in the right package. Another question about telemedicine. Sorry, I'm scrolling here. Telemedicine will help change the future of pediatrics, and this is already happening through medical schemes, but needs to expand to the public sector. Yeah, absolutely. I think there is enough creativity and innovation within the public sector. There are enough people who are willing to push these challenges, these boundaries. What we saw in the session this morning of the ways people have adapted their situation to do these things. There really is great potential for advancing telemedicine and different use of technology in advancing child health care. Yeah.
Okay.
Yes, Natasha.
I was wondering if I've had some time to think about what the thing is in the last 30 years in my time. And interestingly, I think the shift to being less invasive has made a huge difference in neonatology. And we see even in the most vulnerable and the smallest extreme preterms, less in some ways is more. So if you go to the UK, they're not intubating those little ones unless it's absolutely necessary. And that's a big shift because we are intensivists by training. And so we like to do stuff. But moving away from doing that and resisting that urge to touch and do and prick and prod, that to me has been a huge shift for me. Yeah, hands off. And then the second thing is neonatal care actually doesn't stop, as we know, in the facility. The emphasis to ensure that there's actually support with CBS and those models around the world, those are interesting to me to see how we can support the moms post-discharge, especially for the most vulnerable and the burden of disease, which is prematurity. Because as you know, Dave, from the child death reviews, a lot of them go home to die after millions of rands being spent on them. So for me, those two are not related to equipment, but more support.
And doing less invasive stuff with better post-discharge care is a model that is easy to roll out beyond the tertiary units. It's much easier to do that in rural areas and outside of the big centers.
And I think we mustn't forget that the tertiary centers are there. They're there for a reason, but the amount of money we spend is a bit disproportionate to where it's needed for thriving.
Yeah. But we are very much shaped and trained by our training environments, where we study, that really impacts the way your brain works. And the fact that that's the new doctrine in the tertiary centers, the next generation of trainees will carry that out with them, which is a huge step forward. I think that's absolutely brilliant. Yeah. Thanks for that, Natasha. Mark and Chris, any last comments from your side? Any final closing words that you want to leave with us?
Okay, thanks, Dave. Let me jump in and just say I think that the future is going to offer a lot of new opportunities to the people in the room and the people who are still going to be coming into the room in the next 10 and 20 years. And we don't need to, we're not waiting for a silver bullet. We have all the solutions and more coming at us. And it's really just about how we collectively as a team of people can support one another to get those good things to the people who want. Made the point of taking people the things that they ask for. It's just improving. One thing that I would wish for after my little comments on society, it would be better access.
Sorry, Chris, I lost you for a second there. Could you say that last thing again? Sorry, Chris, could you just repeat that last thing?
Are we still struggling? All right. I said, you asked if I could wave a magic wand. So my magic wand number one would be social upliftment and a more egalitarian society. But my wand number two, that if you'll allow, would be just that we make sure that people get access to the healthcare that they want. And that's the big thing that we need to get better and better every year. Thanks.
Oh, that's brilliant. Yeah, that's absolutely golden. I will give you a second wave of the same magic wand. Absolutely. Mark, anything from your side?
Thanks, Dave. I'm going to just, I love quotes. I'm going to end with a quote from David Graeber, who's my sort of favorite anarchist anthropologist. And he said, the ultimate hidden truth of the world is that it is something that we make and could just as easily make differently. And I'll leave it at that.
Can you paste that into the chat?
I will do that.
Cool. Natasha, the last word is yours. Do you have a last fling of the magic wand or closing comment?
I think I live by the dictum, be the change you want to see, don't wait for others. If we are all advocates in our own right, we don't need committees. Our voices are we the advocates, we should take that up quite strongly. And social upliftment is where it's at. We've seen the changes that have happened if you do that. It's time commitment, not easy stuff, you know. But we've got to walk that path because we've done what we can in the facilities. The changes that need to happen are in the societies, and we need to be part of that change and bring the families and communities along. Thanks, Dave, for the
brilliant. Thank you. Thank you very much. Thank you to our panelists for their very, very thoughtful presentations. Really reflected very deeply on that question and have really given us something to think about. Do appreciate that. That really has been a great session. So thank you all for that.